Okay, so for the exam, we do want you to come in and sit in a different seat than usual. You can have one piece of paper, which I will be providing. So you can have your computer, some sort of writing instrument, and some water. And then I'll provide the paper. So those will be the only things that you will have for the test. And then once everybody's in there, I'm going to give the password right at 1 o'clock. So if you're late, that's just, that's when the clock is starting. So you really want to be there. I would say to shoot to be there a half hour early, just to be cautious, so that you can kind of get in there and get everything set up. Everything else needs to be in your locker. All right. And then when you're done with the test, you just, you can leave. You're done for the day. So make sure your computer's charged and that you're there, I would say 30 minutes early. All right. All right. We're going to get going on the slides. And really keep in mind that this test is very foundational. And I really, I think in these slides brought the key content that you need to know. And also keep in mind, this is including everything from the beginning of class. So this is going to include all of Professor Wurz's presentation. So that'll be the vitals and derm. It also includes my presentation on history taking and like SOAP note documenting. You guys, what you're doing with your SOAP notes, tell me that you know all of that already. So just know that there will be some questions about that on the test, but it seems like you guys, I don't think you'll have any problem answering them. It's just kind of like, where do things go and what's in this part of the history? It's stuff that you've already shown me that you've got a good handle on, but there will be some questions about that. I also want to remind you that you want to look at the study guide, because that does pull in questions just about vitals and derm. So take a look at the study guide questions as well. And if you looked at those already and you have any questions for me about the answers, let me know at the end. All right, so the first question is a history taking question. What set of questions can be asked if you're concerned about alcohol tolerance? And really you would be looking for oh my goodness, why isn't this? There we go. The CAGE or the TWEAK questionnaire. Just in general, knowing these questions are ones that you can find online, but the important thing is, do I know these exist and what kind of questions are there? And the difference between them is the CAGE questionnaire focuses on the consequences, where the TWEAK focuses more on alcohol tolerance. But both of the questions are very similar. You would just use one or the other. All right. What is a normal BMI? Again, this is something that you can easily look up, when you have a patient come in, but it is helpful to know kind of in general what numbers are normal. And for the test, you would want to know what numbers are normal versus underweight, overweight, obese, extreme obesity. I think in the real world. Oh, yes.
Sorry, there's some people locked out of the Zoom still. Do you mind
Really?
admitting them?
Yeah. Let's see here.
Sorry, we're at the library and I think we're having some technical difficulties
No
too
problem.
with their Wi-Fi.
Okay. Let's see here. Okay. Okay, I don't see anybody else. Do you guys know of anybody else? No? Okay. Okay. So sorry, for those people that just came, I did go over a little bit of the ground rules and such for when we do the exam on Wednesday. So if you can check with your colleagues about that, just so that you're comfortable, definitely come 20 minutes to a half hour early. Okay. All right. So so just know these BMI numbers, essentially, especially, the normal. So the next question, you guys had a lot of derm information on the study guides. It goes through, just knowing the difference between, where did that go? Describing the plaque, a papule, macule, vesicle, bulla, patch, nodule, pustule, just like knowing what those terms mean is important. And then as far as knowing kind of more specifically and thinking about certain pathologies, it's good to know the skin cancers. So think about what skin cancer looks like: a dome-shaped lesion, translucent pearly white borders, telangiectasias that frequently ulcerates, forming a central depression. And that's going to be your basal cell carcinoma. And there's a picture of it there. There's lots of information about how many are diagnosed and things like that. That kind of stuff is not on this test. The focus is on recognizing abnormal, knowing how those get described. A scaly red papule or plaques, that tends to be your squamous cell carcinoma. And then your melanoma is the one where you're using the ABCDE mnemonic to be evaluating, has anything changed with this lesion? So that's as much derm as I'm going to review, because I think most of it's in the study guide of what to review, but it's really focused in on what I mentioned, just being able to sort of describe or define the ABCDEs and describing those different kinds of lesions that are on your study guide. And describing them meaning, a plaque is elevated, it's superficial, it's solid, it's less than a centimeter. Okay, remember Dr. Wurz's PowerPoint on nail findings, and just be able to recognize, if you look at a picture. So that first one is paronychia, which is a infection along that nail bed. Second one, onychomycosis, which is a fungal infection. These ones, they love these on the pants. I don't know why, but these nail finding mesalines, splint, which is the first one on the left. And those are those areas of those white bands that you see along, I guess I have a pointer, don't I? Right through there, those white bands are those mesalines. This is Bowes lines, which is this kind of, it's often due to trauma, people pushing in on the nails there. These are splinter hemorrhages, which are little areas of bleeding. And these are going to be your terry nails, which is a more opaque nail. So you see it partially opaque there, and the whole nail is opaque there. These all have different, they all kind of represent some sort of systemic illness, but that detail we don't need to get into right now with this test. All right, with the vitals, we also talked about levels of consciousness. So if just getting a general idea, because this is really important, because this is the start of every assessment, alert. Ideally, people are alert and oriented times 3, but if not, then how do you describe that? So for example, a patient that appears drowsy but opens eyes and looks at you, responds to questions, and then falls asleep. So if you remember these different definitions in here, so that would be a definition of lethargy. So just having a basic idea of what these different terms mean, so that when you document them in your note, you're giving the right description. All right, is this an okay pace? Or do you want me to slow down or go faster?
This is okay.
It's okay? Okay. So I have some vignettes here, but honestly, the vignettes in the test are much shorter. They're going to just be like, of all this information, the most key information. But I also wanted to just remind people about old carts. So this is Beatrice with a headache. She's 42, complains of a recurring headache, comes on slowly, feels like a vice around her head, worse after a long day of work. Her husband has similar headaches. It's gradual onset, top of her head, bilateral, lasts from 30 minutes to a week. That's not right. 30 minutes to, like a day. It's pressing, it's tightening, non-throbbing, mild to moderate intensity, worse at the end of the day, but no worse with sneezing, coughing, changing position, there's no nasal congestion, discharge, no worse with a light versus dark room. And it gets worse when she's anxious or has a big deadline at work, and she denies any nausea, vomiting, visual changes, eye pain, dizziness. Oh, sorry. I always hate it when presentations do that. So what are you thinking so far for her? It also, if the feels better, she takes a nap. Scale 2 to 3 on a scale of 1 to 10. That should be, what is this kind of pointing you to?
I was thinking like a tension
headache, yeah. And the big difference, tension headaches tend to be more gradual and bilateral. And then you see with her a lot of triggers, stressful situations, end of the day, triggered by dehydration, stress. So that's a pretty typical tension headache, where a migraine or like a cluster headache tend to be more unilateral. The migraine can be associated with an aura. You could have nausea, vomiting, photosensitivity, and a cluster headache has the other autonomic symptoms of tearing, oh gosh, what else? Rhinorrhea, kind of the eye symptoms that go along with it as well. So let's think about another headache. So this is Pamela. She's 73. She comes with headaches that's getting worse over the last few days. She says it's throbbing mostly on the left side of her head over her eye. She's tried taking Tylenol, but this hasn't helped. She's had similar headaches the last few weeks that have gotten better on their own. The patient has made her a bit nauseated and her jaw feels stuck at times, so she's not been eating well the last few days. The pain is worse when she moves her head or neck. And in the exam, the question would probably just get to the point and tell you this is a unilateral headache. It's just been the last few weeks. It's worse when she opens and closes her mouth. So when you think about headaches kind of in this area, you want to think about the temporal mandibular joint, some sort of inflammation there, which is the situation for this case. Versus trigeminal neuralgia or giant cell arteritis. So trigeminal neuralgia is when there's something pushing on the trigeminal nerve, cranial nerve 5. And so you get this this is really excruciating pain for patients. It's shock-like stabbing, burning. And it's going to be, if you look at the distribution of the trigeminal nerve, it can be anywhere from, the eye, cheek, jaw. Whereas giant cell arteritis is inflammation of that temporal artery. So the artery is inflamed and then it ends up kind of pushing on nerves and causing pain. And again, it tends to be more localized to the temporal area, but can go into the jaw. So just differentiating between those three, which can have similar presentations. Okay. So here's another person with a headache, young guy, 38, comes to your clinic with a headache he's never had before. It's the worst headache of his life. He's also got some neck stiffness. It's sudden. It started a few hours ago. It hurts all over his head, nonstop, intense, rates of 15 on a scale of 1 to 10, meaning it's like over the top. Nothing's making it better. It's worse when he sneezes, coughs, changes position, denies nasal congestion or discharge, no eye pain. His neck's a little stiff, but otherwise, no other symptoms. And I think that's enough information to get the general point. So this one would be a subarachnoid hemorrhage. The key thing with this is that this is a new bleeding in the brain, basically. It's very painful. It happens abruptly. It's often categorized as like a thunderclap headache, meaning like, boom, okay, now you've got this intense headache, or the like worst headache of your life, because this blood is pushing on things in the head when you increase the pressure in your head. So things like coughing, sneezing, any sort of like bearing down is going to put more pressure into your head, and it can make the symptoms worse. So that's a pretty classic subarachnoid hemorrhage. So this is the kind of summary slide for headaches that we had during that, during our lecture. So your primary headaches, we kind of talked about the difference between the migraine, cluster, and tension. Secondary headaches, that's where you would, if on the test, you'd have something else going with it. Like they've had, this headache because of a sinus infection, or meningitis would be more like fevers, chills, neck pain. Or I need new glasses, I'm straining all day and now I have this headache. That would be a headache due to eye refraction problem. And then you've got the subarachnoid hemorrhage we just talked about again, any sort of trauma, the temporal arteritis. So we kind of covered on those. Just know a couple key things about each. All right. You guys ready to move on to the ear? Yes, we are going to talk about the RINA and the Weber tests. And I hope these will, be good practice and you'll feel confident with that, with interpreting those two. So this is Deborah. She's got ear pain. She's 24. Comes to the clinic with 2 days of muffled sound in her right ear. So it's muffled. It started after swim practice the previous week. It's no better after yawning or taking decongestants. Ear is starting to throb, worse when she tries to sleep on that side of her head. Pertinent negatives: no fevers, no chills, headache, sore throat, sneezing, nasal discharge or congestion, mouth lesions or plaques. So no signs of an upper, kind of an upper respiratory or kind of URI. So on whisper test, you have abnormal gross hearing in the right ear. So her complaints in the right ear, her hearing is abnormal in the right ear. So the next thing that you would do is you would move on to the RINA test, which, the RINA goes under the PINA. So you would be checking for bone versus air conduction. So you hit your tuning fork, you're checking here and then listening here. And she has bone conduction is greater than air conduction, which is abnormal. So it would be an abnormal or a positive RINA. And then when you do the Weber test on the top of her head, it lateralizes to the right ear. So question is, what kind of hearing loss? Is it conductive or sensory neural? And what is your next step? So this would be conductive hearing loss. And I really feel like this is the chart that is going to be the most straightforward and helpful. You'll notice here with conductive loss, is when you're going to get an abnormal RNA test. With sensory neural loss, the RNA test is normal. So anytime you get the RNA test, it's going to tell you automatically, are you dealing with conductive or sensory neural? So in her case, she had a positive RNA. So we knew it was a conductive loss. And then the Weber test tells you, you know, which ear. You kind of already know which ear the problem's in because you had the gross hearing was worse in that, I think, right ear with her. Yeah. So the RNA is going to lateralize, meaning you can hear better in the bad ear with a conductive hearing loss. Whereas if it was a sensory neural hearing loss, you would have a normal RNA over here, air conduction greater than bone conduction on both sides. But when you do the Weber, you're going to be able to hear better in the good ear. So I think this chart is the most simplified and probably going to be the one to have in your mind when you're thinking about these questions. But we're going to do a few more questions just to keep going over it.
Professor Rowland, question.
Yeah.
When doing the RNA test, which is on like the left and the right of the ear, which side would be the bad ear, the one that we hear it or we don't hear it?
So with the RNA test, that's when you're comparing bone to air conduction. So you first put it on here, and then after when you can't hear it anymore, you put it here. And if they can still hear it, then air conduction would be longer than bone conduction. And that would be a normal or a negative RNA test. But if you put it here and they say, okay, I can't hear it anymore, and then you put it here and they're like, no, I can't hear that, that would be a positive RNA, because that means the bone conduction lasted longer than the air conduction. And anytime the RNA is positive, that's a conductive hearing loss, not a sensory neural.
Okay, so I had a question. So when there is a positive RNA test, we know that it's a conductive hearing loss and not the sensory neural.
Right.
Okay, but we still go on to do the Weber test just to like double check.
Sometimes the question may or may not include that, but it probably, I mean, if you think about it, like if somebody says, I'm having the problem in this ear, they have gross hearing loss in this ear, you do the RNA and it points to this ear. Yeah, why would you do a Weber test? You probably wouldn't. But if the question includes that information, I just want to make sure you understand, you know, the interpretation that you would see on the Weber test.
Professor?
Yeah.
Could you explain the difference between why for the Weber test on both conductive and sensory neural, why they're different in terms of where they lateralize?
So on the Weber test, so this is bone conduction, right? Because this is really going through the bone. So if it's a conductive hearing loss with the Weber, you're going to actually, it's hard to think about. So the Weber, when you say that this is my bad ear, the right ear, so if you've got a conductive hearing loss, this ear is now responsible for hearing everything. And you're going to actually, the Weber will lateralize to the bad ear, because the ear that can still hear is also picking up all the ambient noise that's going on around. In sensory neural hearing loss, the conduction through here is fine, but something's happening in the very inner ear. And the Weber just lateralizes to the better ear, to the ear with the better hearing. Beyond that, I don't know how to explain it any better. So I apologize if that's not sufficient.
When you
It's
say
hard, it's a
Right.
hard one to wrap your, like the air to bone conduction to me, like makes sense, but this whole ambient noise and how the other ear is actually hearing, not hearing as well because it's blocking out this other stuff, that can be a little harder to understand. That's
when you
why
say lateralized, do you mean like hearing it or feeling it towards that ear?
lateralized meaning, really either one. Like which side, I mean, you usually ask them which side do you hear, but remember you hear through air and you hear through bone. So, the Weber test is just really kind of skipping the other stuff and going right to, the bone to the inner ear. And so when you say here with the Weber test, it's kind of, it could be either one, the bone or the air.
Thank you.
So let's look at this next question. A patient with sensory neural hearing loss in the right ear will hear the sound produced by a tuning fork placed on the middle of the forehead. So you're saying sensory neural hearing loss in the right ear. And if you put a tuning fork on the middle of the forehead, what test is that?
Weber.
It's the Weber, right. So will that patient hear, well, when you put that up there, will they say, I hear it better in the right ear, equally in both, or better in the left ear? We know
Right.
it's not equally in both. And remember with sensory neural loss, you're going to hear with the Weber test, it's going to lateralize to the ear with the best hearing. So the answer would be the left ear. Okay. Any questions on that? So let's think about this again. So a patient with a cholesteoma in the right ear. So where is a cholesteoma? It's going to be in your middle ear. So it's when those three little ossicles in your middle ear, it's like this keratinization happens where there's extra tissue in there and it sticks those bones together. And so this would be a problem. Remember, your outer ear is that ear canal and the pinna, and then your middle ear is going to be the tympanic membrane, and then those little ossicles, as well as the eustachian tube. So any problems with those would be your middle ear. And then in your very inner ear is the cochlea and the cranial nerve 8, the vestibular cochlear nerve. So if the problem is a cholesteoma, that's a middle ear problem. What would you expect the RINA test to tell you if someone had a cholesteoma in the right ear? So is a problem in the middle, the first thing you have to say is the problem in the middle ear, is it a problem in, is that going to cause conductive loss or sensory neural loss? So that's going to cause conductive loss. So what else would cause conductive loss? So like a otitis externa, where that ear canal is really erythematous and swollen and the air waves are not getting through. Like an otitis media, where there's an infection of the tympanic membrane and it's kind of bulging out, or it's red and it's not functioning normal. Or say like your eustachian tube isn't working and now you've got to build up a pressure behind your tympanic membrane and the air sound waves won't be conducted normally through the middle ear. So any of those things are going to give you a conductive loss, potentially. Sometimes you can have those in here just fine. Where the things that are going to give you the sensory neuronal losses are going to be anything that has to do with the very inner ear. So that would be anything to do with the nerve or the cochlea in there. So that would be something like somebody who has like a lot of exposure to loud noises. So someone who works with jackhammer all day, or they go to a lot of concerts, or they're a musician and they're, you know, around loud noise. If there's some sort of tumor growing on the cranial nerve 8. So anything that's happening directly in that middle ear, or just aging, that's the most common cause. As you age, that inner ear just becomes less sensitive to sound waves. So any of those would give you a sensory neural hearing loss. So in this, back to this question. So this patient has a cholesteoma, which is a problem of the middle ear. So would that lead to a conductive or a sensory neural hearing loss? It would be a conductive hearing loss. So then the question is asking, what do you expect to see with the RINA test in the right ear? So if we're talking about a conductive hearing loss, and you were talking about the bad ear, you would expect to see that bone conduction is longer than air conduction, or a positive RINA. So the question, here's your options. Bone conduction is greater than air conduction. That's the answer. Sound lateralizes to the left ear with the Weber test. Nope, it's going to lateralize to the bad ear, and the bad ear is the right ear. Air conduction is greater than bone conduction. No. And damage to the vestibular cochlear nerve. No, because the cholesteoma is in the middle ear, not the inner ear. So I think it'll be important to just kind of think about what causes, just from what we've started to know, like what causes conductive versus sensory neural hearing loss. Like what are a few things that cause each of those? And then how do you interpret the Weber and the RINA test for conductive versus sensory neural? If you know those two things, then you can put the information together to interpret. Let's do one more, because this is fun, right? Okay, Lewis, he's 45. He presents with 4 days of left ear pain. He just started to feel better after getting over 3-day cold with runny nose, yellow discharge, nasal congestion, mild cough, and yellowish phlegm. He does not have a thermometer, but he feels very cold. He feels tired and had to call in sick. He denies a poor appetite, nausea, vomiting, or diarrhea. So on exam, his tragus is mildly tender with palpation. He failed the whisper test. His RINA test was abnormal, so that's telling us he's got some sort of problem in his outer ear or his middle ear. He's got a conduction problem. You look in his ears, and his external auditory canals are intact bilaterally with no discharge. His left tympanic membrane is erythematous, slightly bulging, no cone of light. And then his rest of his exam is not super remarkable, and he has a temperature. So this would be pretty classic otitis media. You know, we talked about, we're mostly on this exam, we're just looking for basic concepts, basic anatomy, with just a few diagnoses sprinkled in there, just some bread and bone diagnoses. So this would be one of them that you'd want to be familiar with. Otitis media is an inflammatory condition that affects the middle ear. And it's not uncommon after a cold, when you've had all this extra phlegm and fluids, and then the eustachian tube isn't draining well. It's not uncommon for that infected fluid to sit behind your eardrum and then turn into a bacterial infection. So classically, you know, starting with upper respiratory infection, you know, evolving into otitis media is pretty common presentation.
Professor Wallen, quick question.
Yeah,
So like reading the case right off the bat because of the tympanic membrane bulging, I kind of thought it was otitis media, but I noticed that it said the tragus was mildly tender with palpation.
yeah. You know, as
bit.
I was reading that, I was like, oh, wait, I thought this was an otitis media one. So I will update that. And that's a really good catch. Tragus is usually otitis externa.
Mhm.
So that I need to improve upon that test questions, but I'm glad you picked up on that. And as I was reading it, it threw me for a loop for a second too.
I thought you were being sneaky.
No, I swear we won't be sneaky on the test. I've looked through all the questions. We've looked through all the stats. I've really tried to simplify things. So I will update this for next time.
Thank you.
Thank you for pointing that out. Okay, so here's Philip with a hearing loss. Philip is 68, so he's old. That's your first clue. He's got hearing loss. He lives alone, but his neighbor says that he needs to turn down his TV. It's too loud. Pertinent positives, progressive hearing loss. He can't tell if it's both ears. No better after yawning or taking decongestants. So what would yawning or decongestants do? It would help open up that eustachian tube. So if there was any sort of inner ear issue, sometimes those maneuvers will help. He doesn't have any ear pain, discharge, fever, chills, headaches, visual changes. And he's got, some past medical history. He's on some medications, whisper test, abnormal gross test hearing on both sides. So what kind of hearing loss do you think this is?
Sensory.
Sensory, yeah, the sensory neural. So no other symptoms going on. He's older, it's bilateral. That's probably what you would have. All right. Okay, are you happy to stop talking about the ears? Or do you have any questions? All right. So let's move on to the throat. Brian's a 37-year-old male with 3-day history of sore throat, non-productive cough, nasal congestion, purulent disc drainage. What mnemonic would you use to direct your line of questions in a patient with this kind of complaint? And how would you describe your findings? So you guys all know the mnemonic, old carts. That's the one you use more so when patient has a complaint to really get down to like the nuts and bolts of what's going on. And I would describe this with petechiae on the oral mucosa, the posterior oropharynx is red, the tonsils are non-enlarged, there's no exudates there. So just thinking a little bit about some of the symptoms of throat complaints and how to describe things. So if you saw these pictures, how would you describe them? And kind of what is the difference between them? For me, the top picture, the kind of the posterior oropharynx, the soft palate looks a little bit red, but the thing that jumps out at me are the tonsils have that kind of creamy white part on it, which is what we call an exudate. So that would be concerning for a bacterial tonsillitis, whereas the bottom one, the tonsils look much more red and enlarged, and depending on the other symptoms, it might also be a bacterial tonsillitis. This is both ones that you would want to do a swab on and see, are you getting any strep back on that? So both two different ways to describe two different kind of tonsils situations. And then what lymph nodes do you think would be enlarged in a patient with complaints of like tonsillar issues?
The cervical lymph.
Yeah, cervical or the tonsillar. Either of those would be perfectly good answers. Remember, your tonsillar are more up, kind of back up here right behind your jaw, where your cervicals are a little bit more down on your neck. And remember what gland is right here? Your parotid gland.
Parotid.
Yeah. So just remember that's where your parotid gland is, and your submandibular gland and your submental. Okay. So what does this describe? An asymmetric, painful, and localized collection of pus that forms in the tissues surrounding the tonsils. This condition typically develops as a complication of untreated or inaccurately treated tonsillitis or strep throat. So that would be describing a paratonsillar abscess. And these look, when you're looking back in the posterior oropharynx, you can see the asymmetry that's happening over here. So here would be kind of one kind of tonsil, one arch over here, and this whole arch, which normally would be opening up like this, is pushed over by this paratonsillar abscess. So it's not an abscess or infection in the tonsil, it's next to it, and it gets so big that it just pushes everything over. And you can see the asymmetry in the back of the oropharynx now. And these patients are really sick. They've got a bad sore throat, fever, pain with opening their mouth. They could be drooling, their voice could sound different. So this would be an advanced tonsillar case. But based on these pictures here, just want you to be able to see the difference between that. So these are both tonsils are involved. This is a infection next to the tonsils pushing everything over. Some of the other stuff that we talked about in the mouth, this is Frederick, he's 62, complains of a sensitive mouth, painful when swallowing, and these weird white spots in his mouth. And then I do mention that he's on steroids, which isn't really something we've talked about, so I won't linger on that, but that's something that can suppress your immune system. And anytime your immune system is suppressed, you're more likely to get fungal infections. So that's what this is. This is a candidiasis, which is a fungal infection in the mouth that can be on, with him, it's on the soft palate and the uvula, maybe the buccal mucosa on the sides, maybe a little bit there on the tongue. And the key thing in diagnosing this is you can scrape that off. So you just go in there with a little tongue depressor, you can scrape off a little bit, you look at it under a slide and confirm that it's fungal, although you wouldn't even normally need to do that, just the presentation could tell you that. But that's how, in one way that it differs from this other complaint of this white plaque-like formation on this person's tongue. This is Vince, he's 72. He's been feeling fatigued, frustrated with his inability to cut back on chewing tobacco. And then you find this finding. And this is different than the oral fungal infection. This is a leukoplakia, which is just a irritation of the mucosa. And you can get kind of these white plaque-like formations below the tongue, buccal mucosa, kind of anywhere in the mouth. And it's just the body is just having this local irritation, in this case, to chewing tobacco. The difference with the oral fungal infection is you can't scrape this off. This is adherent. You can biopsy it, but that would be more aggressive. And you probably do want to biopsy it because if this was due to chewing tobacco, that could be developing into a cancer. But the most important thing is, oh, this is what it looks like. You can't scrape it off. He has a history of having some sort of irritant in his mouth. This you'll recognize from our other lecture, and I'll let you go through this on your own, but here's the matched answers, just understanding what the mouth would look like. If there's any kind of swelling, that's called angioedema. The mouth, or the lips would just be larger than normal. Fissures at the corner of the mouth is angular cheilitis. Scaly red lesions due to sun damage is actinic cheilitis. And then the fluid-filled blisters that burst and scab over are usually herpes labialis. And then same with the tongue, just understanding what different pictures of the tongue look like. So just look in Bates. Geographic tongue is the one that looks a little bit like a map. There's these smooth red areas and denuded areas of the papillae. Canker sore, which is actually, I don't know if you call that a canker sore. I go with aphthous ulcer. It should be APATHOS ulcer. This is a painful, shallow, whitish gray oval ulceration. And often it has like a red halo around it from irritation. Black hairy tongue is literally a black hairy looking tongue. And it's kind of brown black, and the papillae are actually hypertrophied, and they're kind of elongated and bigger than normal. Atrophic glossitis is a smooth and sore tongue. It's kind of red, swollen, but smooth. And varicose veins are just enlarged veins, just like you'd see varicose veins on your arms or legs, or if you see them mostly under the tongue, and they're just these really engorged veins. So take a look in Bates. They have pictures of all of these. So just to be able to look at them and kind of know what description you would assign to them.
I have a quick question.
Mhm.
Are there going to be photos on the test as well?
Yes.
Okay, cool.
All right, let's move on to the eyes. Again, we got a lot of information on Friday, and this is where I'm going to narrow it in for you. So just knowing general vision refraction errors, nearsightedness, farsightedness, focusing problems with aging, what do we call each of these? So nearsightedness is a myopia, farsighted hyperopia, a defect in the eye or in a lens caused by deviation, like the difference in the curvature, is astigmatism, and focusing problems of near objects that are associated with aging, that's presbyopia. So just know what those terms mean. Joel talked about a lot of eye conditions. So just looking at each of these, that first one, there's a lot of injection, number one. There's a lot of injection around the sclera, and remember that membrane over the sclera is called the bulbar conjunctiva. So this is just a lot of extra blood vessels there, and usually that's a sign of conjunctivitis. If there was a problem with the cornea or the conjunctiva, would that be painful? Yes. So I think one of the key things, that he pointed out a few times was just, what things are in the eye are painful and what aren't painful. So I'll kind of review that at the end. But anything involving the cornea and around that area or the iris is going to be painful for the patient. The second picture there is also a corneal. This is conjunctivitis. So this is, an infection or allergic reaction that's causing all this injection. A corneal ulcer, is when there's some sort of scratch or fissure in the cornea, which is incredibly painful. Patients are very photosensitive. It's something that usually happens abruptly. Lots of tearing, lots of foreign body sensation, and sometimes visual change as well. You wouldn't have a picture like this on the test, but I just am using these more to review these different conditions. This one is a little bit more like a iritis, which is an inflammation around the eye. This is called a limbic flush when the injection is just right around the eye. And then this one is an important one to know. This is your angle closure glaucoma, and that's classically an eye that's really painful, unilateral. The cornea is actually cloudy, That's kind of what this picture is trying to depict, and the pupil is fixed. And these people, again, are abruptly miserable, can have nausea, vomiting, intense pain, significant visual changes. So just to remember, you're learning the different parts of the eye, and if there is a inflammation or infection of that part of the eye, what do we call it? So if there's an inflammation of the oh, wait a minute. If there's an inflammation of the iris, we call it iritis. Some of them are obvious. If there's an infection or inflammation of the really inflammation, conjunctivitis, because itis is always inflammation, that is a problem with the conjunctiva here. So that thin layer over the sclera. Keratitis is a inflammation of the cornea. So here, I mean back there. Pinguicula is that inflammation over the sclera that we'll just see a picture of in just a second. Chalazion is a blocked meibomian gland, and xanthelasma are these yellow deposits that's on the eyelids toward the nasal side. So just a way to think about, you know, what are these terms, connect these terms to the part of the eye, and we'll go through some pictures of those. So those are all listed there. So let's go through each of those and just think about them. So conjunctivitis is often what people think of as pink eye, although it can be due to bacterial cause, viral cause, allergic reaction. So that's where you just have to dig deeper. But it's inflammation of the conjunctiva, which is the bulbar conjunctiva here, right on the sclera. And usually you've got discomfort, mild discomfort. You can have watery or purulent drainage, but usually your vision and your pupil are normal. A subconjunctival hemorrhage, we have a picture coming up, but that's a leakage of blood outside of the vessel, one of the blood vessels in the conjunctiva, and it tends to be this sharply demarcated red area. It's not painful, there's no visual changes, the pupil is normal. Iritis or uveitis is inflammation of that middle layer of the eye. And remember, there's 3 different layers. There's the iris, the ciliary body, and the choroid. So here's the ciliary body, the iris, and then the choroid is going to be, we can't see it as well in here, but it's, oh, here it is, this layer, this inner layer all the way around. So depending on exactly what part of those are involved, it could have a more specific name, but in general, just understanding iritis, uveitis is that layer. And that is, tends to be a moderate amount of pain. It can be this achy, deep feeling of pain, photophobia, and the pupil can be small and irregular with visual changes. Other causes of a red eye or eye pain, keratitis, which is the same thing as a corneal inflammation. So a corneal ulcer can give you keratitis. And this, because there's so many nerve endings on the cornea, this is moderately to severely painful. Vision can be decreased, definitely photophobia, but your pupil is going to be normal. And then acute angle closure glaucoma. That is when the pressure in the eye is built up so much that it is starting to cause damage to the optic nerve. And this is, I listed the symptoms on another slide, but that's going to be your like acutely painful eye, lots of injection of the sclera, cloudy cornea, fixed pupil. So I feel like these 3 slides really are going to focus you in on the eye disorders that you want to be familiar with. There's a few others that we'll talk about that I'm coming upon. But any questions on those? So talking about the glaucoma, let's look at this question. Which of these findings in closed angle glaucoma is incorrect? And always make sure that you read the question right so that you're looking for the right thing. So which one of these is not true? Presentation is usually acute and needs to be addressed immediately. That's true. There's copious purulent drainage from the eye. That is not true. You're going to see that more in a conjunctivitis. The condition is due to a bulge in the iris forward from an enlarged lens, causing a narrowing of the angle of the chamber. That can be true. It's not always an enlarged lens. It's just whatever. Remember, Joel talked about it's just a balance. If the ciliary body is making more fluid than the angle of Schlemm and that trabecular network can drain, then you can have you can get glaucoma. But if you do something, or if you do like a dilating agent and the iris gets bigger, you can cause a acute angle glaucoma. So there's different reasons, but that's one of them. And then the last one, eye symptoms include severe pain, photophobia, dilated and fixed pupil, and a cloudy cornea. Yes, those are classic glaucoma symptoms. And I just compared closed angle to open angle. The closed angle is the one we just talked about, that acute increase in the intraocular pressure, but you can have an open angle glaucoma, which is also an increase in that pressure, but it tends to be chronic, slowly progressive. And sometimes patients don't even know it's happening. And that's why when you get a yearly eye checkup, they check your pressures because patients are often asymptomatic. But if it continues to progress, it can cause permanent eye damage. So those are the difference between the closed angle and the open angle. Joel also touched on this, that glaucoma is going to affect the optic nerve differently than, say, like somebody with an increased intracranial pressure. So the reason that glaucoma is putting pressure on the optic nerve is because there's so much pressure in the eyeball that it's pushing back on the optic nerve. And that's where you start seeing a change in your cup to disc ratio. So then there's kind of thinning of the fibers here. So this is a normal cup to disc ratio. So remember, the cup is in the middle and the disc is on the outside. This has clear margins and the ratio is pretty close. And then here you see that the ratio is getting smaller. The cup's getting bigger, and here it just looks like one big cup. And that's going to be classic acute or angle closure glaucoma because there's so much pressure in there that it's just pushing on the optic nerve and thinning out those fibers back there. So on a fundoscopic exam of somebody with closed angle glaucoma, is they're going to have this increased or decrease in the ratio. The cup is going to be almost the same size as the disc. Any questions on glaucoma or those other things
So just to clarify, both the open angle and closed angle glaucoma tend to be unilateral?
Yes.
Okay.
Do I stay somewhere that?
No, I was just.
Yeah, because I mean, if somebody that's where you might see a difference. So just keep in mind, papilledema, the difference between how the optic nerve looks with glaucoma, where the increased pressure is inside in the eye, pushing on the optic nerve, pushing it back. Or you can also see papilledema, which is when pressure is coming from behind the optic nerve. And those are situations like high blood pressure, high intracranial pressure. And that's where you see papilledema, which I actually didn't show a picture of here, but be sure to look in Bates. And that's a different finding where there is, again, increased pressure in the eye, but the pressure's coming through somewhere in the back of the eye, pushing on the optic nerve and pushing it forward. Where this is pressure in the eye, pushing that optic nerve for, further back. And that's when you get the cup to disc ratio. But if you have something pushing on it from in the head forward, that's when you get papilledema. So I didn't put a picture of papilledema, I don't think. So just take a look at that in Bates.
So does papilledema also affect the cup to disc ratio?
I would think so, but I would need to double check on that. I'll let you know.
Okay.
I just write that out. Okay. So another eye finding to be aware of is retinal detachment. And he talked quite a bit about this, where there's the retina is usually right up against the back of the eye, the sclera that's in the back of the eye. And if there's anything that comes between those two layers, it causes retinal detachment and it starts causing visual loss. So classic retinal detachment, let's think about it. So the question says, all of the following are symptoms of retinal detachment except. So flashes of light is true. Because of that detachment, there's a lot of visual changes going on. You can have a complete visual loss, like a dark curtain moving over part of the vision. You can have sudden blurred vision, but you would not have a painful eye with redness around the iris. Retinal detachment is one of your differential for a painless vision of loss of vision. A painless vision loss. Because that retina is detaching and now there's no connection between any of the cone or the rods there with the rest of the eye. And so any of that point, you're going to start having vision loss. But it might look like flashes, it might look like a curtain or a black spot, it might look blurry. So all sorts of different visual changes, but no pain. So that's basically what I put there as well. All right. He went over the eyelid conditions. So this is going to be, let me see. So this is going to be a sty or a horgillum. And that's a blocked meibomian gland. It's different than a chalazion, which is just going to be that same situation, but not painful and red. So a chalazion is when that gland just becomes, like he explained, like just butter in there, and it becomes hard, but it's no longer inflamed. But in the stage where it's inflamed, then it's called a horgillum. So just to know the difference between those two stages, it's a similar thing happening, but it's just a different part of the stage. And a horgillum doesn't necessarily become a chalazion, but if it does persist and the inflammation goes away, then it will be a chalazion. And the best way to treat this, remember, you don't need to know this for the test, but I think it helps me think about the process, is the warm compress to sort of get that gland to drain. So I go through those different things here. Horgillum is same as a sty, abscess of the eyelid, localized. and erythematous, it's painful, there's swelling. Chalazion is that blocked duct without the inflammation. And blepharitis is inflammation of the eyelids at the base of the hair follicles, which still can be blockage of some of those meibomian glands, but it's more diffuse. Xanthelasma is these slightly raised yellow, well-circumscribed cholesterol-filled plaques. And I've got a picture coming up of that. And that would be a sign of somebody who has hypercholesterolemia, is when you have such an excess of cholesterol that it's actually depositing in different parts of your body. Pinguicula is the yellowish triangular nodule on the bulbar conjunctiva, which is just can be caused because of aging or just damage, sun damage or wind. When it progresses over the cornea, then it's called a pterygium. And that's where you are more likely to get involved because with treating it, because it can affect your vision if it's going over your cornea. And I have some pictures of those coming up. These are just different terms to be aware of. Your endotropium is when your eyelid is turned in, which can cause a lot of inflammation to the cornea because your lashes are constantly rubbing up against your cornea. Exotropium is when that eyelid's turned out, and that can cause a very dry eye. Ptosis is when the upper eyelid is drooping, and lid lag is when that upper eyelid is not closing usually, and you can see a white, normally when you look at somebody's eye, oh, that's the next slide. Here, let me go here. Normally, when you look at somebody's eye, you can't see the sclera up here. You can't see the white part. And as this person is looking down, the lid would also come down. So lid lag is when this person's looking down and you could actually see the white sclera over the pupil here because the lid is not moving in conjunction with how the eye is moving. And that's called lid lag. And you're going to see those more with your palsy, cranial nerve palsies coming up. So this is going to be your, describe this. I would say this looks like conjunctivitis. There's just tons of this scleral injection, all these blood vessels in the bulbar conjunctiva. This might also be an exotropion, right? Because this bottom of that lid is kind of going out. This is going to be your hordulum or sty because it's got the inflammation going along with the bump. This is classic angle closure glaucoma. Here's the cloudy cornea, which you see compared to this cornea looks different. The pupil is fixed and dilated. So these are clearly like, if you're looking at somebody and this is their two different eyes, you can clearly see that they're not the same. But this is a classic closed angle glaucoma. Here's your subconjunctival hemorrhage as a blood vessel that's broken. It does not cross into the iris or the pupil, and it's there's no symptoms with it. It just looks visually alarming. And it'll resolve in usually within a month, maybe a couple weeks. And then here is your pterygium, because it's crossing over into the cornea. If it was just staying over here, then it would be the pinguicula. And there's your xanthelasma, which are those cholesterol deposits on the eyelids. It's usually on the nasal side. Okay, so here's Douglas with eye pain, a 34-year-old male who presents with right eye pain, decreased vision since he took out his contact lens the night before. He feels like something in his eye, and his eye won't stop watering. So do you suspect a bacterial conjunctivitis, hordulum, pinguicula, corneal ulcer, or a central artery occlusion? So we know that Horgula is a lid disorder, so that's not what we're talking about. Pinguecula is usually asymptomatic because it's not causing any visual loss, it's not going across the cornea. This could be a bacterial conjunctivitis, but with the classic contact lens, it happened abruptly. The foreign body sensation, the eye pain, that would be a corneal ulcer. Central artery occlusion is when the blood supply, the arterial blood supply to the eye is blocked. And that's where you're going to get the classic pale retina with the cherry red macula. Let's see. Joel talked about some different fundoscopic findings suggestive of diabetic retinopathy. And those are going to be, and this is just due to, people with systemic diabetic retinopathy is going to cause damage to the nerves and the blood vessels throughout your whole body. And so flame hemorrhages are going to be just little blood vessels that get broken and leak. Hard exudates, I think, are kind of the same process. I'm trying to remember what hard exudates. Got my thing here. Yeah, again, like lipid deposits from leaky blood vessels. And then also the cotton wool spots are kind of the same vascular damage. So the only one that does not sound like diabetic retinopathy is that pale retina with the cherry red spot, which is going to be that central artery occlusion that we just talked about. So just knowing if you look at, and you'll have similar findings with hypertensive retinopathy. So just all those damage to the retina from either too high of blood pressure or with diabetics, too high of blood sugar, which causes damages to all the vessels back there. Okay, we're going to move on to the extraocular movements and talk about the cranial nerve palsies for, remember, cranial nerves 3, 4, and 6. And these are ones just to kind of know which nerve innervates, which eye muscles and what eye muscles, how they move the eyes around. So this is a 64-year-old female. She comes in with visual problems in her right eye for the past 6 months. Patient says she finds it difficult to see with her right eye because the eyelid is covering part of her vision. She's also experiencing some double vision. So if the eyelid's covering part of your vision, that would be atosis, where that eyelid's just a little droopy. And double vision tells you something about disconjugate gaze, like both the eyes are not focusing on the same thing. On exam, the right eye is pointing slightly down and out, and the right pupil is 9 millimeters, which is different from the other one. I don't think I said that. The right eyelid is drooping, and the visual field exam is normal except for diplopia. So this is going to be, let's remember the way that the different cranial nerves work. And you just kind of have to figure out how you're going to visualize all of this. But I have in my other slides, the directions that the different cranial nerves point your eyes, whether they're, up and out or down and in. And it's just kind of something that you're going to need to practice and learn. But remember, the lateral rectus, remember LR4, SO6, and then the rest are all cranial nerve 3. So lateral rectus is innervated by cranial nerve 3, LR4, cranial nerve 4, SO6, Superior oblique is cranial nerve 6, and then the rest are all cranial nerve 3. So the patient that we just talked about has a problem with cranial nerve 3. And the really kind of giveaway with this is she has so many things going on, right? Because the cranial nerve 3 is the one that's going to innervate 4 of those muscles, as well as has to do with the eyelid muscles and the pupil muscles. So if she's having all these symptoms, an enlarged pupil, so she's having trouble with meiosis, she's in a mydriasis. If she's having double vision, so that tells you dysconjugate gaze, a droopy eyelid, the ptosis, those are multiple symptoms, and you can sort of deduce from that that it's cranial nerve 3, because that's the one that innervates the majority of the muscles, as well as the pupil and the eyelid. So if you can look in this picture, this is normal looking forward. And with cranial nerve 3, you will see people looking, the affected eye is going to be down and out. And that's kind of another easy way to remember cranial nerve 3. The affected eye is down and out instead of forward. Now let's look at somebody else with a cranial nerve palsy. Jim is a 44-year-old male who keeps tripping when going downstairs because he can't see well. He's also having frequent headaches and unintentional weight loss. So on exam, his red reflex and fundoscopic exams are normal, but on the visual fields in his right eye, he cannot depress the eye out when it's abducted, so he can't go down and out. So I would just remember this picture with cranial nerve 3 palsy. So the affected eye, the gaze is up and superiorly lateral, because this eye muscle is not going down and out. This person can't go down and out, so instead the eye is usually up and in. So I think that's the easy way to remember cranial nerve 4 is the affected eye. Here's the normal eye. This one is up and in. And then you'll also get this history that they'll have often, because the eye is up and in, they can have trouble reading. They can have trouble going downstairs because their eye can't go down. So that would be a common history. If you remember, if you can't see the floor, there's a problem with cranial nerve 4. And that's because the action of the superior oblique, which usually goes down and out, is not working. So this patient is left with this eye kind of going up and in. And that's what somebody with a cranial nerve 4 palsy will look like, which you can also see in this picture. So she can look over to the right, okay, but if she's looking straight, her gaze is up and in. And that's a classic cranial nerve palsy. These ones are hard. I think these are one of the hardest part of this unit. But where I would focus is this picture. And remember, the affected eye is down and out. And then with cranial nerve 4, the affected eye is up and in. And they have trouble doing stuff down because that superior oblique isn't pulling the eye in and out.
Professor Wallen,
Yeah.
I have a quick question about this. So for the previous example of the cranial nerve 3, it's saying that it's down and out, right? Wouldn't that be superior oblique, which is a cranial nerve 4 then instead as well?
The tricky thing, the thing that I think for me is hard to figure out with cranial nerve 3 is there's so many nerves that are involved that you have to think of all of them in unison. So it makes sense to me with cranial nerve 4. So the affected gaze is up and superior because the superior oblique, which pulls it down and out, is not working. So it's kind of like the opposite. That's a little more straightforward, but I think with cranial nerve 3, it's a little trickier because it also innervates 3 other, 4 muscles total. And it's hard to think about, well, if this isn't, these 4 aren't working. So I don't know a more clear way to explain that. I always remember this one is going to be down and out, is going to be the affected gaze. Because I have a hard time thinking of like 4 muscles that aren't working and all the ways that they go. So for me, it's either easier as a default to think about, in the end, what the affected gaze looks like. But with cranial nerve 4, this is going to be how the affected gaze is because the down and out's not working, the superior oblique. I don't know if anybody else has a better way to kind of think through cranial nerve 3. The other thing with cranial nerve 3 is you're going to have your eyelid and your pupil symptoms along with it generally. And these people are going to compensate by tilting their head back to try to get that right eye to look up.
Thank you.
Okay, sorry, that's not the best answer, but I want to keep it, I'm trying to keep things as simplified as possible. And really what we would be looking for is like looking at this picture, what nerve palsy are you suspecting, or a very short vignette of like these different symptoms are happening, which cranial nerve are you suspecting? And keep in mind with 3, because it innervates so many things, you're going to have a lot of symptoms. Cranial nerve 4, the gaze is going to be up and in. They're not able to do down and out. So they're going to have trouble with anything where they're looking down, like reading or stairs. And then, we didn't talk about cranial nerve 6, but that one's kind of an easy one because cranial nerve 6 is LR6, so it's the lateral rectus. So if your lateral rectus, which pulls your eye laterally, isn't working, then the defect you're going to see is just an eye pointing in because the medial rectus will be pulling it nasally. So cranial nerve 6 will just look like, I have it in my slides. I guess I didn't put it in this slide set. The eye will be pointing in because that lateral rectus can't pull it back laterally. Okay, we're nearing the end here. It's almost 2:30, so if people need to go, that's okay, but we just have a few more questions. Patient comes to you with complaints of double vision, especially at night when she is tired. What is the first test to evaluate for double vision, diplopia? And what does this test tell you? Double vision is because the gaze is not conjugate. Eyes are looking in 2 different places. So your first one is your corneal light reflex. And then, your next test would be the cover uncover test, which we talked a little bit about a few times. So cover uncover, you cover the eye, the good eye, and you see if the other eye is able to focus in. A patient's concerned that in photographs, only his right eye reflects back red. What is the name of the test that you could do to evaluate this complaint? So that would be the red reflex, which is the beginning of your fundoscopic exam. And you're looking for that first picture there is normal. There, the left eye, you're not getting a normal red reflex. And on that one, the right eye, you're not, or in the left eye, you're not getting a normal red reflex. And that can be signs of, classically in a kid, you would think retinoblastoma, which is a tumor that that goes along the vestibular cochlear. No, that's your ear, along your optic nerve. So that's what you'll always see on tests for sure. So this is just a summary of eye tests. Corneal light reflex or conjugate position is evaluating if the eyes are conjugate or aligned. And that's going to be a good one to start looking into any cranial nerve palsies, along with your extraocular movements, your H. Your secondary test, if you want to look further, would be your cover-uncover test. Your EOMs are for cranial nerves 3, 4, and 6. Your red reflex is looking for an obstruction that's preventing light from reflecting back. That's what we just talked about. Your pupillary light reflex gives you information on cranial nerves 2 and 3. And if you found an abnormal pupillary light reflex, or even just in our testing, we're doing the accommodation test where you're moving the finger toward the nose and you're looking for both eyes to be following in and moving more nasally and the pupils contracting. And then visual fields also are going to be looking for a hemianopsia or a horizontal defect. So just understanding those tests, what they are and what they're looking for. Okay, any other eye question? We've just got a couple more questions left about lymph nodes. Okay, so Florence is a 72-year-old female who noticed a new lump in her chest last week when she was putting on her favorite necklace. The lump has not changed. It does not hurt. It's the same color as her skin. She's not had any new activities. She feels a little more tired and she's been losing weight, which she's pleased with, but hasn't really been trying. And you find a 3-centimeter rubbery, non-tender, fixed supraclavicular lymph node. So does that lymph node sound like a inflamed lymph node or a malignant lymph node?
Malignant.
Malignant, yep. So classically, malignant lymph nodes are non-tender. They tend to be bigger than inflamed lymph nodes. They tend to be rubbery or hard and fixed or non-mobile. They don't just move around. If you feel your cervical lymph nodes, you can kind of move them around, but a malignant lymph node will be more fixed. And the supraclavicular are really are where the lymphatic drainage is for your abdomen. So they would be here, infraclavicular there. Which lymph nodes are located over the parotid gland?
The parotid lymph nodes.
Your parotid lymph nodes. I had to end on a really positive, easy note, right? So don't overthink things sometimes, but do know where these lymph nodes are. So parotid lymph nodes are right over your parotid gland. Parotid lymph nodes, would feel tender, they would move around, but a parotid gland inflammation would just be like red area here, your gland, or lots of tenderness here. It tends to be unilateral. But just know where these lymph nodes are. Your tonsillar lymph nodes are right back here. Preauricular, postauricular, you guys know those from doing our physical exam practice. So that's it. Is there any questions? Did you guys find the study guide? Have you had a chance to look through that?
I had a quick question on the study guide.
Yeah. Yep.
Okay, number 6, it says to list the most acute to least acute, and then we were just not sure how to categorize headache because it just depends on the severity, so we weren't sure how we should rank that.
Oh my gosh. Maybe I have a different study guide. Where did you find that study guide?
Oh, sorry, I actually numbered it, but it says it's in the beginning.
Oh.
a patient with toe complaint for 5 years, headache, vision loss, seasonal allergies.
Oh, I see. Okay.
Rank them. Mhm.
Oh, so it's sort of saying, so keeping in mind, so if this is like the classic patient who comes in and they have this whole laundry list of things that are wrong, but you need to focus somewhere. And in their best interest, you want to focus on the things that are going to be the most acute, meaning like most serious, most likely to cause a big problem. So in somebody like this, let's see. So toe pain, intermittent toe pain, no. Headache, maybe. Vision loss, yeah. Seasonal allergies, eh. So like, to me, the most serious to least serious that I'd want to address would be the vision loss, because that is not normal. Headaches can be normal, or they could be a sign of something serious. So I would put that second. Seasonal allergies would be third. Well, I don't know, seasonal allergies and toe pain. No, toe pain over the last 5 years, whatever, toe pain happens. If they're walking around and it's not, just given the information you have, that would be last for me. So vision loss, definitely abnormal. Headaches, as we've learned, they can mean, something kind of benign to like a subarachnoid hemorrhage, which is very serious. And then seasonal allergies, which can be really kind of, it just keeps going on. It can make you feel fairly poorly, and then toe pain. So that's what they mean, most acute, most serious. Where would you want to focus first with that list?
Okay, thank you. That's what I have.
That makes sense?
Professor, I have a question as well.
Yeah.
Oh, Jasmine, do you want to go first?
Yeah, it was just a quick one. I was just gonna ask, I saw that it's 80 questions. How much time do we have?
So you have 75 seconds per question. So on the pants, let me stop sharing so that I can see you all. The pants, you have a minute per question. So we try to get you there eventually, but for these questions, you'll have, I think, 75 seconds. It's like over a minute. And my vignettes were long. Like most of the vignettes are 3 sentences at the most. And some questions are as simple as, name the eyelid condition in this picture. Boom. And that's something that would potentially take you a couple seconds probably. These are all fairly straightforward, but I think there are, I'm just finishing up the test. There's going to be somewhere between 75 and 80 questions, but they won't be nearly as long as the ones I just threw at you.
So I had a question about the study guide.
Okay.
So when it talks about the interpret the following, the number 2 about the year, it was the 44-year-old female sound engineer. So there was lateralization to the left ear, and then it says the left ear has a air conduction greater than the bone conduction, 20 seconds, and the right ear was 5 seconds. So what do you mean about? Can we like break that down? I wasn't sure which ear is the affected one.
Okay, so I'm seeing the 60-year-old male with the Weber test that lateralizes to the left.
No, the next one.
The next one. Okay, 44-year-old sound engineer. This is more wordy than the test is going to be, but let's talk about it anyway. Okay, Weber test. So this is a sound engineer. So what is that telling you? Probably conductive or sensory neural.
Maybe sensory neural.
Yeah. So long-term damage to the ear nerves. So that's like your first clue that's probably where it's headed. I always like to look at the RINA test first, honestly, even though it's telling me the Weber test. So the RINA test shows that the left ear, let's see, left ear air conduction is greater than. So these 5-second, 20-second things, this is not a helpful test because it doesn't matter. The big picture is air conduction longer than bone conduction? So in the left ear, air conduction is greater than bone conduction. And in the right ear, air conduction is greater than bone conduction. So that's a negative RINA. So that again is ruling out a conductive hearing loss. So that's again telling you sensory neural. And then the Weber test shows lateralization to the left ear. Let's see. So what type of hearing loss? I think sensory neural, you've kind of landed on. Which ear is affected? So in sensory neural, you're going to be able to hear better in your better ear. So this is lateralizing to the left ear. So the ear that's affected is going to be the right ear.
Okay. Okay.
Does that make sense?
Yeah. So she can hear from both, but better in the left ear than the right ear. That's what it's
Right.
okay. Got it.
Right. So it's kind of, yeah, that when it says it lateralizes to a certain ear, that means which ear does it hear better in?
Okay.
But when they say which one is affected, it's going to be opposite to the side that it lateralizes to. Because the side that it lateralizes to is the good ear.
Because it's sensory neural. Okay, got it. Thank you.
Yeah. Really, like, if I was you, I would walk into the room, or unless you have a good like photographic memory, walk into the room that you've got a piece of paper. And it's always a good time to like scribble down anything that like visually or that you want to remember. Just scribble down that chart and it'll have all the answers. That one chart with the conductive versus sensory neural. But really, the RINA test I would always look for first, because that's going to tell you conduction versus sensory neural. And then remembering that in conductive, you're going to hear, it's going to lateralize to the bad ear, the affected ear. And in sensory neural, it's going to lateralize to the good ear or the unaffected ear. Okay.
Thank you.
Yeah. Any other questions on the study guide or anything else? One thing on the like visual fields, like the hemianopsias, you don't need to know where along like the optic tract the problem is. You just need to be able to hear somebody's symptoms or see a picture and name it. Oh, that's a homonymous hemianopsia. That's a heteronomous heteronomous homeanopsia. So that's the level that you need to know. You don't need to say, based on these, are they having a stroke? Are they having, a problem in the eye? Are they having a lesion in the optic chiasma? So we're not at that level.
I do have a question about the first visual field loss one.
Yeah,
And it's a horizontal defect. That's it?
that would be it.
Oh.
Yeah, it'd be a left horizontal defect.
Okay. I didn't know if it was like as simple as that, but
Yeah.
okay.
Yep, that was it. Good. And remember, you're naming the visual defects, so you're naming what's black, not what they're seeing. So you're naming where they can't see, not what they can see.
I just had a question on the oral health modules. Are we going to be tested on those as well?
Not much. I'll just leave it at that.
Thank you.
I wanted to ask, other than the photos of the diseases in the textbook, how much weightage should we give to the Bates reading?
I mean, if the Bates helps, I don't think there's anything that's been pulled out of Bates that we haven't talked about in lecture. So if reading the Bates helps to like just that, going over the information again and, just over and over and over. But there's no information in there that hasn't been in the lectures that you would need to know. I think you're right. The pictures are going to be the really, going to be definitely helpful use of Bates. Anybody else? Let me
Is-
look at that. Oh, go ahead.
Is the exam going to be more weighted towards head, ears, eyes, nose, throat?
It's, I would say a little bit.